I'm going to speak on a vertebral artery injury, and anyone who is operating on a cervical spine, I think he should be aware of the normal vertebral artery anatomy, its variations, and if you encounter a vertebral artery injury, which is supposed to be a catastrophic complication, how to deal with it. And that are the basic thing that one should be aware when one is doing in a cervical spine any intervention. So we all know that the vertebral artery contributes to the vertebrovascular circulation, and it supplies the posterior part of the brain. And there are various segments, which is like an extraosseous segment, taking its origin from subclavian artery to enter into the 6-6. Then it traverses through the foramen transversarium to come out at the craniovertebral junction. That is the third part. And after that, it goes intracerebral or intradural. That is the fourth part. So what is the outcome that any particular person who is operating will first think what will happen to my patient? And the outcome is very variable. You may have a completely asymptomatic patient with no postoperative deterioration to a patient who will have a posterior cerebral circulation stroke and including the death. So this completely depends entirely on the competency of the circle of Willis. So you may get a bilateral vertebral artery injury or even a dominant vertebral artery injury and still you may get away. Or you may have something called as a critical vertebral artery, where you have one-sided dominant vertebral artery, other one is a hypoplastic and an incompetent circle of Willis or absent posterior communicating artery, and then you will get a complete kind of a full manifestation in terms of a lethal vascular complication. So the symptoms are usually the all posterior cerebral circulation stroke symptoms. These are dizziness, visual changes, ataxia, loss of consciousness, and ultimately they landed in a death. So coming to the first segment and how do we deal with this segment individually. So we all know that the segment starts at the origin from the subclavian artery and it enters into the C6 foramen in 90% of the patients, and in 10% it may not be C6 foramen. The vertebral artery may enter into the C5 foramen, which is the commonest one, and the second is a C7. So what does that to do with us? So whenever we're doing a cervical corpectomy, please understand if the vertebral artery is entering into the C5 foramen, that means your vertebral artery is anterior to the body or the transverse process. And if you venture out laterally and go on dissecting, this artery may get injured. So it's very important to stay sub-longus coli and not go over the longus coli, because there may be a vertebral artery which is lying there. So it's very important to analyze your imaging beforehand you do a dissection. The second is a V2 segment where the vertebral artery traverses through the C6 to the C3 foramen transversarium. And we all know that the vertebral artery is more anterior and lateral in a lower subaxial spine, and as it goes upward, it goes more medial and posterior. So that is how it has an impact on a corpectomy. When we are doing a corpectomy, we usually restrict our corpectomy dissection medial to the uncovertebral joint. When you are near the medial edge of the uncovertebral joint, you are just 5 mm away from the vertebral foramen transversarium. If you want to just decompress the cord, you can restrict your dissection till here. But if you want to decompress the root, you cannot go beyond 5 mm beyond this margin. There are sometimes the vertebral artery has a kinking in which that the vertebral artery is coming medial to the uncovertebral joint, and if you are not aware of that, you can easily injure that vertebral artery. The other important thing is that sometimes the vertebral artery can have a loop inside the vertebra, and if you are not seeing your preoperative imaging properly, and if you go on doing a corpectomy as you do standard approach, then you will land up in a foramen and you will cause an injury to the vertebral artery. Another thing which if you have done the corpectomy, you realize as you start going laterally, you get a venous bleeding, and that is a surrogate marker that you are very close to the vertebral artery, and that will be the first step before you injure a vertebral artery. So moment you start getting a significant venous bleeding, just stop that in that area. Sometimes the vertebral artery injury is pre-existing. So you are not injured, the vertebral artery is already injured, like in a cervical spine fractures, and fracture itself has caused an injury. And we have extensively published about this. This article, we have also said that even on a plain MRI, you can see the signal intensity change from the damaged vertebral artery, which appears hyperintense as compared to the normal flowing blood, which is dark. So if you study your preoperative MRI properly, you can also get to know what is the status of vertebral artery beforehand as well. We normally, for a V2 segment, commonly the posterior instrumentation, we commonly use a lateral mass, and we all know we want to direct the lateral mass outward. Because if you direct straight on, you have a chance to cause a vertebral artery injury. And that is what the disadvantage of Rai Camille over a Magral technique. The cervical pedicle screw is a very technical, challenging procedure where the vertebral artery is just lying lateral to your pedicle and there's a spinal canal medially. But in certain cases like this, where there's a significant cervicothoracic destruction that we see commonly at KEM, we usually do a cervical pedicle screw. But this requires a lot of fluoroscopy and extensive meticulous technique to avoid any damage to the vertebral artery. Or if you get a neglected trauma like a cervicothoracic dislocation where you are not able to going to reduce it with just a tapering rod or lateral mass, the cervical pedicle screw comes in handy. But one has to be very technically meticulous when you are dealing with this kind of a cases. Coming to the V3 segment, which is one of the commonest area where the vertebral artery gets injured. This is the area where the artery gets injured commonly because of drilling, tapping, or passing the screw. And one has to be very careful. So there's something called the high riding vertebral artery, where the vertebral artery, once it takes origin from the C3 transverse foramen, it goes upward and it takes turn, which is slightly more posterior, more higher, and more dorsal. So what is the implication? Is that when you are passing any transarticular screw, the vertebral artery is going to come directly in your path. Or for that matter, even a par screw, the vertebral artery is going to come on your path. So it's very important to identify this high riding vertebral artery, and there is a clear-cut definite criteria for this, like a C7, the pedicle diameter of the C2, the isthmus diameter should be less than 5 mm, the pedicle diameter should be 4 mm, and they do something called as a vertical height. So all these parameters should be measured before. And sometimes, in spite of doing that, you may have to pass the C2 transarticular screw, then try to keep your trajectory medially, because medial wall is thicker, lateral wall is thinner, and you have vertebral artery lying there. So try to direct it medially as well as high as possible, because there's an arch which you want to negotiate. In conditions like rheumatoid arthritis, there's always a destruction of a lateral mass, so one has to be careful. Or if you do an incomplete reduction, because we've been trained in a transarticular screw, always aim towards the C1, the arch, and we want to aim it. But if you have incomplete reduction, the arch is going to come down, and if you go, you will go through the foramen and you will injure the vertebral artery. So these are the important things, that you should have a good reduction beforehand. And there are certain common vertebral artery malformations, the most common being the first segmental artery, where the vertebral artery, instead of traversing over a C1 arch like this on a normal side, it passes underneath the C1 arch. Or there is a fenestrated vertebral artery, where the vertebral artery is coming on top of the C1 arch as well as the down of the C1 arch. Or there's something called as a pica, where the posterior inferior cerebral artery taking its origin outside the dura over the C1 arch. And if you injure this, there's something called as a pica syndrome, which is nothing but a significant infection of the medulla and the cerebellum, and patient can have a disastrous outcome like a dysphagia, dysarthria, and a paralysis. Another thing is that we do a Goel and Ham technique, C1 and C2 fixation. It's very important to restrict your dissection on the superior arch of the C1 for almost 7 to 8 millimeter. Don't go beyond that, because the vertebral artery will be lying on a C1 superior edge, and in general you should not exceed more than 15 millimeter, because the facet joint beyond that, there will be a vertebral artery which is lying down. There's a peculiar abnormality which is called as a ponticulus posticus. Normally the vertebral artery lies on a C1 arch, and if there is a calcification of this bony formation, the artery is covered in the bony tunnel, and a lot of people want to avoid the venous plexus which is between the C1 and C2, and they take a origin on a C1 arch. And if you are ignorant about this particular anomaly, you will directly enter in the vertebral artery and can cause a disastrous injury. Other thing is that the C1 screw, a lot of time we keep them quite prominent, but please understand, until there is an internal carotid artery, the only factor which is going to protect you from injuring the internal carotid artery is how much is your medial angulation. So that is another thing which one should keep in mind. And there are common strategy which I would suggest is that as a surgeon, you should be aware of the 3D reconstruction. You cannot do your reconstruction by the multiplanar. Here, this patient has a absent vertebral artery on the right side and a dominant vertebral artery on the left side. We operated this last month only. You can see there's a dysplastic C2 pars, and the vertebral artery is dominant, which is a common scenario in 50% of the patients. So the dominant artery comes on the left side. Here you have to explore the alternative fixation like hooks or a sublaminar wiring or a C2 laminar screw. Always I ask my fellows or residents that you should start with the normal side. You don't want to injure the affected or a treacherous course of the vertebral artery, and which is usually the right side. But again, remember, the right side or the non-dominant side is the side where the pica is likely to be more. Always try to refrain the passing a screw when there is a high riding vertebral artery. And if you injure a vertebral artery, just stop the procedure, abandon it. Don't try to cannulate the other side. You don't want to cause a bilateral vertebral artery injury, and one should just do a bone grafting or a wiring and should come out. Again, there's a lot of cervical transforaminal steroid injections which are given through the corridor, but please understand this is a normal spine with a good space for the vertebral artery and needle to go down. But in a spondylolytic spine, the facet is hypertrophied, there's an uncovertebral osteophyte, the vertebral artery is pushed behind, and if you try to enter, you are likely to inject in the vertebral artery, and just aspirating the blood is not a foolproof method to that you are not in a vessel. So try to give extraforaminal non-particulate steroid in these kind of cases. Suppose you have taken all these precautions and still you got a vertebral artery injury, so how would you tackle that? If you have to see whether you have an intraosseous or extraosseous injury, if it's an intraosseous, most of my colleague will agree that they'll continue with the pedicle screw on that side, will stop the tamponade, will pass a bone wax. If it's an extraosseous screw, keep a finger pressure, but keep it for a longer time. Don't try to come and see again there's a bleeding happening or not. You have to use the hemostatic agents which should not embolize in the posterior circulation. Inform anesthetic for aggressive intravenous access. Call for a backup, vascular surgeon. Endovascular backup is nowadays available very easily. Whenever possible, direct repair is always a better choice, but a lot of time the patient is hemodynamically unstable and you may not be able to do it. Always try to see the backflow. If you have a good backflow, that means the vertebral artery, the collateral circulation is patent, and in that case, you can consider a good repair. If you are not having any backup and if you have significant laceration, then a lot of time the bypass is considered because the circulation is not patent. Please remember, tying up the vessel is the last resort, and in spite of doing that, there's a 12% chance of mortality, so it should be kept as a last resort and tie on both ends because you don't want a pseudoaneurysm or a AV fistula formations. We start these patients on anticoagulation and antiplatelet. There is a lot of debate in the literature. When there's a tamponade, do you start antiplatelet, anticoagulant, but it's settled unless you have a direct transaction or a significant intracerebral hemorrhage, you start the antiplatelet and anticoagulant as early as possible. And we also want to prevent the post-operative complication. So if you control the bleeding with tamponade, well and good, come out, do endovascular intervention, check whether there's any thrombus formation which can further embolize the circulation, or is there a pseudoaneurysm or a bleeding forming which you can coil and repair. So this is a case where you can see that there's a significant first segmental intersegmental artery which is lying exactly over the C1 C2 foramen, and in this case we avoid the approach and we do a anterior cage placement and then do a posterior atlant occipital fusion. This we have published. For lack of time I will not go into the detail. Another young patient child with a cervical myelopathy, low set hairline. You can see that the vertebral artery on a 3D multiplanar reconstruction is just 5 mm away from the spinous process, and if you're not well prepared and if you go in, you are likely to injure a vertebral artery. Not only that, surprisingly we saw, apart from the hemi-occipitalized atlas, there was an extradural venous sinus. So this venous sinus was coming from the cranium and was going into the soft tissue. This is his the CD reconstruction, where you can see that the sinus is coming from the skull and it is going in the area of C2, C3. So we were very meticulous while dissecting this sinus intraoperatively, and we dissected so that we did not injure this kind of a sinus. We did all posterior approach. The occipital cervical fusion was done. We could reduce this AAD from all posterior. We restored the clivus canal angle, and this was fused. So the point is that it's very important that you do the multiplanar reconstruction, or you see the anatomy by yourself, plan for it, prepare for the worst so that you will have a desirable outcome at the end. Thank you for your patient listening.